Hello, welcome to the Gut Check Project. I am one of your hosts, Eric Rieger, joined by the main host in the captain's chair, Dr. Kenneth Brown. He's never been on my show. He's only been on our show. What's up, Ken?
How are you, Eric?
I'm doing well.
That was an interesting introduction.
Just so people know, we definitely look at what they say whenever they write into the show.
Somebody wrote in because I guess on our last episode, Eric said, I'm your host, Eric Rieger, and today I have the marvelous Dr. Brown. And somebody said, wow, Dr. Brown is such a frequent guest on your show.
Yeah. So we read and understand, and I think that's funny. So thanks for being here, Ken.
Yeah, thanks for letting me on your show, Eric. I am super, super excited about today. And the reason is, I'm just going to say low dose naltrexone, LDN. If you don't know what it is, you're going to really want to listen. If you've ever heard of it, you're really going to want to listen. And I have a particular passion for this one for two reasons.
Go for it.
So today we have Sebastion Denison, who is an expert on this, and we're going to introduce him in a second. But the reason why I'm so passionate about this is just 2 weeks ago, I was on Gabrielle Lyon's podcast.
Oh, yeah.
Dr. Lyon podcast. She has a huge following. And during the podcast, she kind of pinned me down. She's like, do you know much about LDN? And I'm like, golly, I don't. She's like, neither do I, but we really should get ourselves up to speed. And I was in Houston doing it. And I'm like, listen, I think we have our LDN expert that's coming on our show in a couple weeks, lives here in Houston. So I'm going to make sure that you hook up with her so you can, she specifically said that she wants to learn more about it as well. So that's number one. And then number two, one of my partners tried to get, because she likes using LDN with her patients and does get it from Allen Family Drug, which is where we get ours. She sent me an email where she wanted to have it put on our EMR, our electronic medical record, so that it's just a drop down. Everything's electronic now. And she received some obscure email from somebody that said, we are not going to put this on because there's no scientific evidence of any of this. And that just infuriated me. So we are going to talk some science today about LDN and maybe educate some of the people that did not want to put it on the EMR. So this is both to educate myself and to possibly educate others who knee-jerked and denied putting it on the electronic medical record. So
I think it's awesome because whenever I know of naltrexone from the anesthesia point of view, it is strictly only been introduced mostly for an introduction of a drug to help people who've been struggling with opioid addiction and for people in some slight instances around alcohol, but even though that application isn't as widely known as the opioid. So honestly, Ken, you bringing that to my attention that people were using it outside of that, certainly within the functional medical space over the last several months, has opened my eyes. And I think that there are just a litany of applications that have been ignored. And anyway, I'm super excited to have the guest on.
Yeah. So if you're somebody that has thyroid issues, Hashimoto's thyroiditis, any autoimmune issues, struggling with pain, depression, anything with the immune system,
weight issues,
you're going to want to hear this because I am actually doing a little research for this. It opened my eyes and I am absolutely shocked why I've not been utilizing this as an adjunct to even traditional therapy. It's not an either or. This should be an adjunct to a lot of things. So let's jump in here. All right. The person you are looking at, this handsome man who clearly is an Evel Knievel aficionado, is Sebastion Denison. He is a pharmacist who received his degree from the University of British Columbia, and he worked in Vancouver for over 11 years, specializing in hormone replacement therapy, pain, and sports compounding. He was also the manager of pharmacy operations with the 2010 Vancouver Winter Olympics, and then the manager of the Whistler Olympic Village Polyclinic Pharmacy. Sebastion works as a clinical compounding pharmacist in Houston, Texas currently, and is part of both the U.S. and Canadian Comprehensive Compounding Course Education Team. He presents to physicians, pharmacists, and other healthcare professionals at educational symposium and events, including the American Academy of Anti-Aging Medicine on nutrition and alternative uses for naltrexone. Sebastion, welcome to the Gut Check Project.
Thank you so much. I'm kind of blown away because this is the most exciting podcast I've been on. Like seriously,
Well,
this
we
is
should probably
really
end it
fun.
right now.
Yeah,
Oh yeah, let's we can talk about Evil Knievel if you'd prefer, but I'm pretty jazzed up about naltrexone, probably more so than Evil Knievel.
that's awesome. Well, I know that you have spoken extensively all over. And let's just start with some basics. I am this is like I'm asking Chat GPT to explain low dose naltrexone for a 5-year-old.
Okay. Um, I'm going to jump back a little bit because this is actually keyed into something you said. You've heard a lot about it over the last few months, and people are getting more buzz around it. Um, I got to take you back to 1994, 1995, and a gentleman by the name of Dr. Bahari was actually doing a lot of HIV research at the time, and he was looking at the effect of naltrexone in these HIV patients, where they were seeing this significant increase in their endorphin levels, like a 300-fold increase with these fractional doses of naltrexone. And at the time, there was not a lot of other drugs out there to treat HIV patients. And so this was big news because they saw this concomitant increase in endorphins and this increase in immune cell function. And so it was helping these patients at the time. Right around that time in the pharmacy world, we introduced the reverse transcriptase drugs. And so we saw this proliferation of treatment options for HIV patients. And naltrexone all of a sudden became kind of this, well, we're using it for reversing opioid toxicity and a little bit for alcohol use disorder. So yeah, we'll see where it goes. But what got really interesting in that time frame is that this group of patients that were struggling with diseases that weren't really getting any sort of airtime, I guess, or respect, fibromyalgia, MS, chronic fatigue syndrome. Remember, this is mid 90s to late 90s. And there wasn't this push of care for these patients because they weren't really well identified. And there wasn't this sort of pathophys to these patients. They were just kind of sick and tired and sore all the time. And they were looking for some help. So once we introduced naltrexone into that group of patients back in the late 90s, all of a sudden that's where we saw LDN picking up. In the following 30 years, so to speak, we've seen this increase in usage, much better understanding of functionality of the drug, where it works in all these receptors in the body, and then this proliferation of application. So that's pretty much where it started. But I'm going to take you back. You mentioned, Eric, that it was alcohol use disorder, very minor amount. And in the anesthesia world, naltrexone, naloxone are the two big molecules for reversing toxic opioid use.
Correct.
So we use it orally for patients who are like, yeah, we don't want you to go back and use opioids recreationally or systemically. And we have naloxone kits that are widely distributed now in pharmacy application for patients who are kind of overdosing on all sorts of stuff. So we're kind of like, we're still tied to that indicated use. And that's what's in the US and Canadian approval positions. Those are those two indicated uses. But what we didn't understand at the time was where naltrexone also works. So you said like a 5-year-old, you ready? So I'm going to see if I can do this. In pharmacy, people think that a drug has one site of action. And you think about those commercials where you see the ibuprofen go in and it goes to the knee and it fixes the knee. And people are kind of like, okay, I understand that. So one drug, one receptor. Naltrexone actually has approximately, to date, 16 different receptor sites that it can work. And it's got 7 in the opioid receptor system. So there's 7 opioid receptors that are now identified. And there's 7 TLR receptors in your immune system, and then something called the OGF receptor. And then finally, there's this ACE2 receptor in your kidney tissue, angiotensin converting enzyme 2 receptor site that is also implicated in, you ready for this? COVID. And I don't want to get you guys,
We've already been banned off YouTube. Don't worry. So
all right,
we're
okay.
on. This video portion's on Rumble where everybody's cool with it. So
okay. So where the COVID molecule spike receptor protein attaches to the ACE2 receptor is where naltrexone can actually block that binding domain. So there's a lot more going on with naltrexone than there was originally thought of, this endorphin push, because The endorphin push is good because you kind of have this feeling of well-being, you have this increase in energy, and you overall see this net response in the patient. But it's the immune cell modulation that we are really excited about, that we've really kind of seen blow up since about 2014, 2015. That's where we saw this dramatic turn in the use of naltrexone. And it was really coming from the compounding pharmacies like Allen Pharmacy, that they said, hey, if we start putting this into more patients, we should see this change in their overall health pattern. And to your point, if we're already doing care for these patients, we can actually see an improvement in the current care paradigm. So if we're looking after a patient through and I'm going to think GI space, your current work in the GI space will see an improvement because we're doing an immune modulatory response. We're changing an inflammatory response to a normalization response. So you're taking away drivers of sickness. That's effectively it.
Interesting. Eric and I actually did, we went to a conference called the FLCCC. Have you ever heard of that before?
Yes, I have heard of them.
So that's
I haven't
the
gone to any of the
frontline
conferences yet.
Yeah, frontline critical care COVID workers. That's all those doctors that sort of at the beginning of COVID, they got banned. And Dr. Mobeen.
Oh yeah, Mobeen Syed.
When we had him on the podcast, he was talking about methylene blue in a different way, but he briefly touched on low dose naltrexone. And I went to his website recently and he just put a whole lecture on this at the most recent FLCCC. He gave a whole lecture on LDN and its relationship to COVID. So he's brilliant and does such a good job of teaching. So when you said that, that's interesting that he just gave a lecture on that and it's on his website. So,
well, the interesting thing is you and I have already agreed that we know various drugs and their indications early after, let's say, the FDA's approved it. You know, there's this one thing, and something that I think the public isn't always aware of is the amount of times that an approved drug is used, what they call off-label, but it's done every day, hundreds of thousands of times. I mean, even as something as critical and basic as labor and delivery, you've got something like Cytotec used for stomach ulcers, but it's also great for L&D whenever they need to thin the cervix for ease of delivery. So, and that's not indicated on there. So there's all kinds of different drugs which are used routinely every single day off label. So this exploration off label for naltrexone is not foreign or unique into itself. It's just an exploration on safe ways to use naltrexone.
And I think it's a very crucial point, is to the indicated use is where we get the approval and the patent protection. There's can be patents of use, and there's patent on process, and then there's patent on the actual molecule. In this particular instance, we're now past the patent expiry date for naltrexone, and this is why we call it alternate uses. But we're also looking at fractional doses of what was originally brought to market. We've seen doses in the alcohol use disorder, as well as now off-label for other addiction purposes, everything from gambling to internet to even behavior addiction, so beyond just opioid drugs, for treatment purposes. So that was up to 150 to 300 milligrams. And we're talking about low-dose naltrexone, which is on the exact opposite end of the spectrum, which is somewhere between 0.1 milligram up to about 10 milligrams. And what is also useful information for everyone is there's something called a hormesis effect. And so this is where my hands are going to get really excited. In any drug, there's a dose response curve, and we see it does this, and it kind of goes up, and you see this optimization effect, and then it drops off the other side. But there's also something called a hermetic effect, or hormesis, where you can see differential effects at different points on the curve. So things like ultra low dose naltrexone, which is a different conversation. This is something that was explored by Purdue Pharma back in 1999 to 2002. They were looking at microgram doses of naltrexone to stop the escalation of opioid drugs, to very low dose to low dose naltrexone, which is kind of in the middle of this response curve. And you see the effects start to get lost as you increase the doses past that 10 milligrams. I'm not saying it's an abrupt cutoff in any patient, but you can see this immunomodulatory response between 0.1 all the way up to about 10, 12 milligrams. And then it starts losing that immunomodulatory effect as you go to the higher doses, because it's saturating all of those receptors. It's having a differential effect. So hormesis, being a very technical term, it's that dose response curve that you can see unique properties to the drug at different doses. Methylene blue, you just mentioned it. We use that for acute treatment. We can use that for toxic exposure to other medications. We can also use it when patients are crashing. But now we're starting to see this dosing range of 2.5 to about 30 milligrams, as you said, for the mitochondrial support, for anti-aging purposes, for patients with post-COVID, neurodegeneration, very unique, different properties at these different doses. And the off-label exploration of drugs, really and truly, that's where we kind of go is, what do we know that they're currently using for what happens at different doses or different dosing strategies? So very, very cool.
Just more of a historical thing. Did you say Purdue Pharma was doing the research on this?
I want to say it was oxycodone with Purdue. I want to say it was Purdue back in 99.
So Purdue that ultimately created this thing was actually toying with low dose naltrexone.
Ultra low dose naltrexone back in 99 through to 2001. They actually
I wonder if they were doing that to find out, don't let this information out.
No, they had a commercial product out, but physicians didn't want to write 2 narcotic scripts for one patient.
Oh my gosh.
Because they had a dose in the morning, they had a dose in the evening. They couldn't figure out how to do a dual packaging at the time. It didn't go anywhere, but we still see a lot of discussion about ultra low dose naltrexone for high dose opioid patients to stop dose escalation, as well as increasing sensitivity to the dose that they're getting. Very cool.
Fascinating.
There's so much science here. Like you guys don't have enough time for this.
Dude, we are going to geek out because this is the thing. When somebody knee jerks and says, oh, there's not science on this, and then they don't even know anything about what it even represents. And you're talking about data with the hormetic effect, where up to this point, we are really optimizing the immune system. Beyond this, it's a completely different effect. That in itself is so fascinating, because there's some dialed in science right there.
Well, let's go back to 2007. Actually, again, back to Evel Knievel discussion. In the 90s, early 90s, we didn't know what these toll-like receptors are in our immune system. We didn't know. And I had the great fortune of working with a provider who did an MD PhD in the 90s. And that was the outcome of her research, was the identification of these toll-like receptors in about 1995, 96. And I remember learning about them in university. It was just like, this is really cool. Since then, it was in 2007 that they first identified that naltrexone fit into specifically a TLR4 receptor in the immune system. And it had these differential effects that we would normally see in opioids. Depending upon the dose, you could actually see a modulatory response or a saturation antagonistic, like just stop the receptor from functioning altogether. And that was in 2007. By 2014, they identified it much better, and they understood the mechanism and the modulatory response. And this is where it exploded. So being super geeky, your toll-like receptors, which are found throughout your entire immune system, and there's 10 in humans, there's more in mice and other animals, but this is a conserved pathogen identifying receptor system in your immune system that goes, hey, there's something in your body that we don't like. We're going to initiate from this point, top down, an inflammatory response. And it goes through something called the JAK-STAT pathway, and it'll eventually upregulate NF-kappa B, which is sort of the mother molecule of all rheumatology as well as GI dysfunction. Because when you have too much NF-kappa, you will actually see an upregulation in inflammatory cytokines. There's 24 that we've identified, 17 which are majority related to diseases, but the top ones are IL-1 beta, IL-6, IL-8, IL-12. And those ones, when they become highly upregulated and dysfunctionally regulated, literally leads to almost all chronic diseases, including all autoimmune disorders. And now I'm going to point directly at you, Kenneth, all GI dysfunction. Because once you have that chronic inflammation in the gut, you have this hyperpermeable barrier. You have a decrease in serotonin production. You have an increase in absorption of lipopolysaccharides. So you kick off more inflammation, which leads to all sorts of other problems. And to kind of focus in on the gut, we know that the microbiome dysfunction along with high inflammation and, I don't know, a high stress event, I don't know, take a recession or, I don't know, COVID infection, knocks you off the boat, and all of a sudden you got an autoimmune or autoimmune-like disorder. So it's kind of this trifecta of chaos that you have going, starting in the gut, this to our world. And this is where naltrexone can fit in.
And we're going to stop this particular podcast for a special invitation.
This invitation is to join the Gut Check Project Raw Locals community.
We all are tired of the bullshit where we turn for great information, who we can trust, and essentially we want to put a stop to that.
There's a lot of bullshit out there, and I know about that because I'm a butt doctor. We're here to build this community to bring trust back to you. There is a lot of shit out there. There's a lot of stuff being censored, and it stops here with our community.
And I'm a gas passer, which means I put this guy's patients to sleep. I know that you don't want to be filled up with any hot air.
Ultimately, we want you to connect with us. Ask us questions. Let's build a community around trust. No more bullshit.
So if you're watching or listening on Rumble, click that red join button in the bottom right over here, and that will take you directly to GCP Raw.
We're super excited for you to join. I mean, seriously, it's going to be pretty cool.
It is going to be, dude, it is going to be cool, but it's hot as hell in here right now.
Are we done? Should we just walk off?
That's Paul. That's it.
It settles down chronic inflammatory dysregulation.
So if I were to explain this, I'm thinking about it in just super, super simple terms. Eric's the analogy guy here, but I'm going to attempt an analogy.
Okay.
Go for it.
Usually I geek out and then Eric's like, well, what he's trying to say is it's like this. So I'm going to try an analogy and see if you can.
So you're saying I geeked out and you're going to try the analogy. Okay.
Yes. Gotcha. All right. So toll-like receptors, the way that I'm thinking of it is if you have a castle and you have guards at the front of the castle, toll-like receptors, they see something and they scream to or basically you have watch guards, they scream to the army and they're like, somebody's coming, go do something. And they scream, and then that turns on, and they do that by sending IL-6, sending IL-12, and then NF-kappa beta is the big group of army men that come out, and they're the whole line of them because NF-kappa beta mobilizes the whole immune system. And so you have these toll-like receptors out there. But if you have over-eager toll-like receptors that scream at everything all the time, then they're mobilizing this inflammatory unit that keeps leaving the castle to go fight whatever's there. Maybe it doesn't need to be fought. Maybe it just needs to be calmed down and be like, no, that's a parade. We don't need to attack the parade this time. So toll-like receptors can become overstimulated. And what we're probably going to get into is how low-dose naltrexone just kind of says, hey, guard, you don't have to yell at everything. Yell at that thing over there that is an invader, but we don't have to do this because when you are doing that at all times, it's chronic inflammation. Can you think of a different analogy?
No, I think it's actually pretty good. In fact, after reading more in depth on low dose naltrexone, what it kind of spoke to me, what you said hormesis earlier, and hormesis is almost like a way to stress the body. The way I kind of think of it's a way to stress the body so that you kind of reset, so that you basically return to a better homeostatic level. And it seems to me like naltrexone functions as a catalyst to reset. And I think there's a bunch of different applications, both in autoimmune disease, weight. It's not even really weight loss to me. It's like weight control, and I want to get to that. But it seems to me like naltrexone is this catalyst to allow your cells, your TL, oh man, goodness gracious.
Your white blood cells.
Yeah, toll-like receptors, TLRs.
Yep. Et
cetera, to basically re-recognize what requires massive alert, what requires just monitoring, and what doesn't require a response at all. And I think it happens at that same level over and over and over again.
And you've nailed it. Like that's what naltrexone does. It modulates. It doesn't suppress, which is a crucial distinction.
Mm-hmm.
And that modulatory response happens through all of your immune system.
So I'm sorry, go ahead.
No, please go ahead.
I just like the application of that, because when you think of like somebody who's got chronic inflammation, and oftentimes we run to steroids. But what happens whenever we run to steroids specifically? Well, now you're trying to control this large inflammation thing. So the steroids get thrown into the mix, and suddenly there's no response. And let's say that somebody has a bad chronic lung infection and we give them steroids. We're worried that they're going to get super sick. Now we're worried about the balance of turning off the immune system. And it's almost like now naltrexone's able to come in and be like this teacher, okay, y'all stay over here. Everybody calm down. We're still going to have class. We're still going to keep moving forward. We're not shutting down all the machinery, but we're just not going to have these disruptions anymore. And it's like rebalancing, recalibrating rather than turning on and off all of the responses.
Yeah, Sebastion, it's interesting because in my world, in the gastroenterology world, there's obviously big money in treating Crohn's disease and ulcerative colitis with these biologics. And each new biologic that comes out tries to hit one of those cytokine pathways in a more specific way. There's now 1223, it started out as TNF alpha and this and that. Makes a whole lot more sense to just start from the very beginning, modulate what's going to happen, instead of trying to knock out the interleukin 12 way down the pathway, because it's still being turned on over here. It's still producing.
Yeah, I agree.
At the very least, it's should be some sort of augmentation of these pharmaceutical drugs that we're using, heavy, expensive pharmaceutical drugs.
It's like you heard me talk before at some point, because the science of the biologics is so interesting, like from science point, geek point. At the same breath, you are targeting one particular endpoint product. Remember I said there's 24, 17 that we worry about, but there's a few main ones. But what happens if you knock out just one of them? You hobble and to use your analogy, okay, we've got the watchtower, we've got the guards, we've got NF Kappa comes out, we've got all of our proper people out there. And this is to continue your analogy, but there's no one who's organizing the army. There's no captains, there's no generals. It's just everyone's flooding out of the city. So you're leaving the city open to different attacks, or kind of porous, so to speak. And you're just leading to more problems because everyone gets excited. Everyone's nervous. Everyone is freaking out. And there's no direction and no focus. And that there's a number of factors leading to that dysfunction. But when you use something like a biologic, it's coming in and it's going to target only specific points of that immune system end product, which will then, it's like taking away all of their left shoes. Every single person out of them who's ready to fight is like, I don't have a left shoe, and everyone's looking for a left shoe. And so what are people going to do? They're going to hop around on the right foot, which means that they're not going to be able to function optimally when there is a problem.
Yeah.
And so this is what leads to increased risk of weird infections, inability to mount in a proper adaptive response. You may have an exaggerated response, because your immune system is to work in this harmony concert, and it's a balancing act of all these cytokines. To remove one piece, you're just taking cards out of a house of cards, and eventually your immune system just kind of freaks out and collapses. Or conversely, it goes in the wrong direction and it overproduces other items to compensate for that loss of those particular end products. And this is why biologics, you see dose escalations, you see failure over time. And I'm sure you've seen it in your practice where you actually have to change to a different biologic.
100%. Like
all the time.
Inevitable at this point. Like we've learned that it's inevitable.
Yeah, 3 years or so, maybe 5 if you're lucky. So you bring naltrexone in, and I take away all of from the top down, like you said. All of a sudden, we have this modulatory response, and what happens to your biologic? It works better because there's less of it needed. So your dose escalation doesn't occur. It can last longer because you have a rebalancing and a reset, like you said. So all of a sudden, things are working better. Everything that you do, all of your other drugs, and there's actually studies on this going back to 2019 where we see a reduction in other medications, safe use of naltrexone in conjunction with current therapies. So you see a net reduction and overall decrease in exacerbations and symptomology in these patients, not just in the GI world, but we see it in rheumatoid arthritis and other autoimmune disorders. We see it in depression, anxiety, fibromyalgia, like it just, the list goes on. And to your comment, it's this adjunct care that improves your current treatment. So it's kind of added in. And there, by the way, to the person who said there is no scientific evidence, that is staggering to me. That's like saying there's no proof that an eclipse happened. Were you not outside? Like did you go outside in Dallas? No, no, no. I was busy. I was up in Minnesota, so I didn't see it. So therefore it doesn't exist. Did you look? Because there's now papers that say fundamentally this is the known mechanism of naltrexone in this receptor family, and this is how it works. And
wow.
Review papers going back to 2018 all the way through. There was a paper that was released literally 2 weeks ago that talks about functionality in the TLR system as well as in the opioid receptor system. And Dr. Ian Zagon, he would be crushed. He's from Penn State, and his team, McLaughlin, etc. They have been working since 2001 on the opioid growth factor receptor axis, which is part of your opioid system, and talking about the discussion of where naltrexone fits in with tissue proliferation, so hypertrophy and metastatic growth, and where its role is in cancers. So for this particular person to say there's no scientific evidence, I would argue you didn't look. And what are you looking for? Because there's literally 3 volumes of books written by physicians and practitioners and researchers currently that are out there. And I can probably find a paper in the next 5 minutes if you wanted me to do a quick Google Scholar search, review paper talking about mechanisms. It's mind boggling. It's like, you're just lazy. You didn't even look.
Well, yeah, that's it. But we were actually talking before we started this. We were actually discussing that unfortunately in traditional medicine, it seems like if a drug rep is not handing you a detailed piece, then the science doesn't exist. Check this out. You were telling me about that. Now it makes a little bit of sense, because even the people that have tolerated and have controlled their inflammatory bowel disease over time, I have now had patients long enough where they are, and we know it's a known risk, they're starting to develop recurrent skin cancers. And so I'm working with the dermatologist trying to find a different biologic to do this. And my explanation was just quite honestly shit poor. I'm like, I guess it's a side effect. But now, from now on, it's like, why am I getting these skin cancers? You're only wearing a right shoe.
Yeah.
That's it.
Yeah.
What are you going to do about it? Here's your left shoe.
Yeah. Paul's not going to like the fact that
maybe that could potentially mitigate some of these other side effects, not only dose escalation, not only failure, but also these other problems that we see, like this recurrent skin cancer in some of these people. That's what I'm dealing with right now with about 3 people, because I've had them in my practice for like 20 years and they've done remarkable and it's great. And then all of a sudden we're seeing this now. Now I'm working with dermatologists trying to figure out what regimen to use.
So we could do I would get you to talk to Joe and Andy, because they'll probably be like, we can help you. But where we can put this in, and going back, the right shoe analogy is very powerful. But imagine everyone's loaded up with, extra left boots and extra swords. And by the way, I'm going to also give you some firecrackers, and those might blow you up. So sure. And just walk around like with only left shoe and too much other problems and other armaments. Things are going to go wrong very, very quickly, because you have a compensatory effect in your immune system. It's designed to protect you. And if it can't do its job, it's going to overdo its job. That's just it. So, but naltrexone fits in and it modulates. And the crucial piece, remember the hormesis discussion and return to normal, and I'm going to steal your term, homeostatic response, is you have to keep it in low doses, because if you do too much, you have the compensatory effect at the high end of dose. So you have to find the right dose for the patient. We call it the sweet spot. That's our nice, very clinical term to patients. But really and truly, it's that dose titration response, and it has to be individualized. It can't be a mass marketed thing. And that's what we found out really and truly back in the early 2000s. We had patients who were coming in and they had MS and fibromyalgia and migraine patients. That was our core group back then. And each patient was dose specific. We had a rough idea. Hey, you're going to be somewhere between 2 and 3 milligrams, but where are you going to be? We don't know until we find the right spot for you. And when we saw worsening of their current symptoms, increase in headaches, my gut started getting funny. Oh yeah, it was working fine. Then all of a sudden I noticed that some of my symptoms came back. I started getting sore again. I started seeing these flares. Dose is too high. Back down. And that is the weirdest thing for most providers. oh, you've got side effects you have to tolerate, and we're just going to keep increasing the dose. No, 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 no. Go back the other way.
Mm.
We've gone too far.
Are there any blood markers that you have found that you could follow?
Well, we have to go back to, and yes, I have. There's a number, and this is a way more detailed conversation that I'm sure your provider group will really appreciate. Is we have to establish a patient on low dose naltrexone for approximately 3 months at a stable dose before you start seeing sort of normalization of specific blood markers specific to the patient. So if you have a patient who, and you mentioned Hashimoto's earlier, once you have a patient stabilized on a naltrexone protocol, you can follow their TSH and their TPO antibodies, but you'll see them start to decrease at that 3-month mark. If you test too early, you might actually see an increase for the first 4 to 6 weeks. If your dose goes too high, you'll see this concomitant starting increasing trend. If your dose is too low, it will just kind of flatten and might stay elevated, but you see a moderate change. When you get the dose right, you just see it starting to tip over and it will come down to a lower set point. For your patients with autoimmune disorders, it's going to be an ANA. And if you can pull a cytokine panel, you can literally look at things like IL-1 beta, IL-6, IL-8, IL-12. There's a whole list of them. TNF alpha. NF kappa, if you're looking at autoimmune disorder patients, that was kind of the big one. There's a few studies that show it, but if someone wants to do that panel, that would be great. But you need about 3 to 6 months of stable dosing before you will see that modulatory response. And that's the big piece to naltrexone. People are always like, oh, I haven't noticed anything. I've been on it for a week. Can I increase the dose? And it's like, whoa. If you talk to any of your pharmacy colleagues in the room, they'll tell you right away, yeah, you got to start low, go slow, and kind of creep them up, because if we go too far too fast, you can actually see this nasty wake up of the immune system very rapidly to a negative endpoint for the patient. Headaches, they feel crummy, everything hurts, they're mad at you because you made it feel worse. GI patients are like, yeah, it was great for about 3 to 5 days and now things are worse. Too much, too far, too fast. GI patients, you can look at inflammatory cytokines, you can any of your normal markers. These are all standard of care and you see them tip downwards. Biologic patients, I'm hesitant to jump in here, but you actually see a stabilization of pretty much all of your monitoring parameters you would for your monitoring of your biologics. And then you start to think to yourself, oh, the biologics working really, really well. No, the naltrexone is kicked in and all of a sudden your biologic is working infinitely better. We've got a GI specialist here. She speaks for us through our team in Katie, and she's actually successfully migrated patients off biologics and reserved them for acute need or decreased doses and still using the steroids when getting a flare. But it's kind of a unique one where you just see DMARDs. What blood markers are you following? What liver enzymes? Normalization. Patients just come in, all of a sudden you're like, if I didn't know you were sick, everything's returned to normal. You're not sick anymore.
In preparation for you to come onto the show, I was trying to research like what other practitioners in the functional medicine space, and they all tell a very similar story. Started off as a traditional allopathic MD, and then they end up someone, just like what Ken said, someone introduced them to this new method, this new use of low dose naltrexone. And it's awesome to hear you say the markers, because it's every single marker that you listed, and plus I think SED rate was the other thing that
ESR
to monitor that, but
CRP.
But everything else is exactly what you laid out on how he monitors. But he started off also saying that his preliminary training took him, regular dose naltrexone was 50 milligrams to 100 milligrams, and sometimes even more for somebody who's got an opioid issue. And he said, even when he was first introduced to low dose naltrexone, and Ken and I talked about this earlier this morning, there was typically, he said, there was this ballpark between 0.5 milligrams and 1.5 milligrams. And he said in that time, he's treated so many different patients, so he actually starts at 100 mics or 0.1 and then begins to titrate up using exactly what you said is his markers. And he said 2 to 3 months is when you'll start seeing these hopefully favorable changes. He said that there are very few times, but sometimes someone might even have to drop a little bit lower than even the 0.1, which is fascinating to me. That's something that gets dosed at 50 milligrams and above for someone who is struggling with opioids for that desired effect. It's a completely different drug and use by itself at a low dose. And I mean, there's just so many different applications. I almost kind of want, I mean, to talk about the mechanism of action on each one of these from oh, I'm sorry. One last thing I was going to ask you in that dosing parameter though. He said that early in treatment that he learned that he wants to dose in the morning. And the reason specifically was sometimes you can elicit heavy visual dreams that aren't always very pleasant if you do it later in the day. And so you can give the patient a time to adjust if they dose in the morning. What's your experience with that?
I can't see Andy and Joe in the studio with you, but
they're
I'm sure
nodding.
they're probably just nodding their
They're
heads.
nodding
They're like,
viciously.
yep. So and I got to talk about the dosing, and then I promise I'm going to answer your question.
Sure.
Originally, Dr. Bahari back in the 90s and right up until about 2013, he was saying between 1 and 3 milligrams is a good dose, but you may notice that you have side effects, so dose down. And somewhere in there, and I'm going to say a really smart pharmacist said, hey, listen, if I make 1.5 milligram capsules, you can take one of those, or you can take 2, and that'll give you 3 milligrams. And you could go up to 4.5. So you could take 3 capsules, and that might work for you, but you got to be flexible on it. And somehow that got entrenched into this idea that you have to start at 1.5, 3, 4.5. And we have worked very hard within our community to say, no. You need to start at, in some cases, 0.5 milligrams if you have an especially sensitive patient. And I'm going to use this term, which I learned from someone else. Patients who are allergic and sensitive to air. You know, we tried an ibuprofen and they said that knocked them out for 3 days. That's not a side effect of ibuprofen, but sure. We give them vitamin D and they end up with a rash. We give them a fractional dose of something and they're super sensitive. We can start at the 0.001, and I'm pointing at Joe and Andy. With a compounding pharmacist, we can make that accurately every single time. Yeah. Because we've got the technique. We're pharmacists. We know how to do those titrations and dilutions properly, but you can't do it with a 50 milligram tablet and a cup of water because it just doesn't work. So back to the comment on the dose is we definitely start these patients much, much lower, titrate them up to negative, back down, and we find the perfect sweet spot. I had migraine patients on 1.6 milligrams and that worked for them, but their colleague, who's also, and I'm trying to be careful here, HIPAA, they were on a 2.3 milligram. And then we had an MS patient who was on 3.35. Like all over the place. It's specific to the patient. And you've already touched upon it. That high dose has completely different properties of a low dose. And this is where it gets really dorky and really exciting. All of those receptors that I've said, all 16 of them, they actually have SNPs that lead to potentiation of disease. There's actually a lot of literature on TLR receptor SNPs that can potentiate specific autoimmune disorders or specific disease patterns or susceptibility to sickness, as well as in the opioid receptors. We see it with things like sensitivity to opioids, addiction patterns, behavior patterns, like there's a lot there. And then especially in the ACE2 receptor site, sensitivity and susceptibility to COVID, genetic variation. So I'm gonna ask a question, and this is totally unfair. Have either of you gotten COVID?
If I did, I didn't know it.
Same. Yeah. Okay. I mean, I think I've had a couple times where I spiked a high fever and it didn't.
I did prophylactically do FLCCC stuff.
Yeah.
But
did you have any patients that got it like 5-7 times in like
yeah.
Genetic variation. So when we go back to the drug, so let's go back to drug delivery and drug sensitization, we have the same genetic material that causes us to be sick, well, it's going to have the same genetic susceptibility to the drug. So this is why we see this huge, sorry, I'm trying to fill up as much as I can of the variation in low dose naltrexone dosing protocols that we can't ignore. That
Okay, say that one more time,
low.
because this is super interesting. What you're saying is that you have a genetic susceptibility possibly to the ACE2 receptor, and you're going to get COVID a bunch of times, but you're saying this also explains why people can have variations in their response to LDN.
Not just the ACE receptor, the TLR receptors, the opioid receptors, your liver biotransformants, and then also the overall, and you're going to love this, gut health. How well do you absorb it? Some patients, they can't tolerate it orally because it gives them a ton of GI distress. So we do sublingual because we still get the same absorption patterns. And so we can actually convert the route of the admin based upon how they're responding to the drug.
All right. So I'm going to admit something that I have completely been doing this totally wrong. If you give me that the dose is between 1.5 to 4.5, I've literally had the conversation. We're going to work your way up to 4.5 because I'm a goal-oriented person, and we're going to get you on the what I'm calling optimal dose. I've completely done it wrong. I've literally said you're going to do this for 2 weeks and this for 2 weeks, and we're going to work our way up. And if you don't have any side effects, you're golden. You're going to ride out 4.5. Totally wrong. So I think I've screwed up a lot of people.
No. Don't be so hard on yourself. We actually had this conversation, and I say we as a community, LDN Research Trust, which is a really good open source website. If you want to find really good articles and information, this is where all of the, and I'm saying this, all of the people that I respect and listen to, they are all there. Linda Ellsgood put this together through the kindness of her heart. It's a charity organization, but it's literally the best and brightest. And the people who publish papers present at these LDN conferences. And we had the same conversation last June, specifically about dosing. And everyone was kind of like, you mean? And I was like, yeah, it's you have to do patient specific. And we see a differential response rate. So I think in the literature, we see about a 50% response rate. And this is a big discussion. And people are like, yeah, it just didn't work for my patients. Half of them works. And we see it in the literature. But if we do a dose titration specific to patient need, and we give them that 3 months stable dose, we're seeing response rates significantly higher. I'm gonna point to some documents where we're seeing about a 90% response rate.
Whoa.
Yeah. We have a clinic in North Dakota. They're pulling their data for patients who are treated for 3 months at a stable dose, patient response. That's where some of the data is coming from. And we have multiple clinics like this where they're seeing 500 to 1,000 patients of low-dose naltrexone, all dose specific.
So my conversation, this is fascinating to me. So my conversation is using what you just said. This is a whole different conversation with somebody. When we find your optimal dose, you have a 90% chance of getting improvement. It may take some time to find it, but let's be patient together and let's work our way. This is what the plan is over the next year, because we're going to go 3 months, 3 months, 3 months. Am I saying this right? If I'm having a conversation where it's a commitment to the use of this modality.
Yep. And here's, just to bend it a little bit further, some of the patients who are tolerating these really small doses, like 0.1, 0.2, 0.5, we can't go higher for whatever reason. We just give it to them for longer effect. 3 months is kind of where we say is a minimum point, but we've seen patients continue to improve out to 2 years once they're on a stable dose that works for them. So it's minor stuff. And they'll tell you, they're like, I don't notice that. I don't notice it. But then all of a sudden they're talking about like, oh yeah, I was out for a walk. And you're like, you were out for a walk? Yeah. You got out of bed? Yeah. You haven't been out of bed in 6 months. Yeah, I felt like going. And you see these little small steps that they're not quite aware is an improvement. And then at 2 years, you kind of go, well, what do you think? Well, I think I'm going to just stop naltrexone. A week later, they're like, oh my God, my life is deteriorating again. It's that significant. So it is. And I'm going to point at your colleagues in the studio, Joe and Andy, they'll tell you all day long, yes, this is what we see. This is what we see. We have to encourage our patients. We have to trust the immune system response.
We do have Joe and Andy in
Joe's
here.
been
So Joe
sitting in his chair here. So
yeah.
Oh, okay. So in the studio here with us is we have the owner of Allen Family Drug, Andy Komuves, and Joe Bertrand, who's a pharmacist also. And he was just saying that when they give this to physicians, they have a protocol that they like to at least give them a guideline of what they should start with, and they start lower and explain the timeline to try and keep the physician like me who just wants to work our way to the highest possible dose. Yep. If you put a number over here, I'm going to try and hit it. That's my goal. So
I'm kind of curious. Oh, go ahead, Joe.
So it's been my experience.
Sorry, I've derailed your podcast here.
150,000 dosage units of naltrexone in my little pharmacy. That's a bunch. So we've seen lots of patients, lots of different indications for use. And Sebastian's exactly right. One dose doesn't fit everybody for sure. What we've seen most frequently is a dosing strategy is to start at either 0.5 if they're sensitive, or 1.5 milligrams, and then every 7 days increase. To your point, 4.5 was always the goal. And there's nothing wrong with going to 4.5, but you have to be aware of the patient. And that's why I love the idea of looking at markers at 3 or 6 months down the road, because then you can really dial it in. Especially sometimes patients do a great job explaining what's going on with their bodies, and sometimes they're just missing it. Well, they had this improvement, but on the other side, this isn't working like it used to work. So, but I would say in my experience, somewhere between 3 milligrams and 4.5 for autoimmune disorders, inflammatory responses tends to be the sweet spot. If you're looking for behavioral changes, like you want to use it as an adjunct for diet, or from some different psychological disorders, like including depression, then you're above 6, somewhere between 6 and 10 is just numbers that I've seen that seem to work.
Sounds good.
It does sound good. Hey, a lot of this kind of strings back to one central thing, though, and it seems to me that most of these different activities that we're starting to discover where naltrexone fits in, it's almost always beginning with nerves. It's all neurons. It seems like that there's some implication in and around neuronal health, making certain that the immune system and the protection around nerves works well. I think that there's some level of activity for the immunity within the brain with glial cells, as well as you mentioned somebody a while ago that was being treated for MS, which of course would be an indictment on a failure of Schwann cells, which is just another type of glial cell. But effectively, it seems like when you get down to gut inflammation, you talk about this all the time, Ken, the gut-brain axis. It's literally the neuronal connection between the gut and the brain. And we have this breach with somebody who has bad gut health, and ultimately ends up in insomnia. It ultimately ends up in anxiety, depression, and just various things that go along with poor gut health. And it seems like what you're being able to demonstrate with good use LDN or low dose naltrexone is a reset of the neural health so that the enteric nervous system is now not eliciting this repetitive inflammatory cascade. Is that kind of how we can start to explain why it seems that naltrexone works?
I that is one aspect of it. Absolutely. There's a ton of information, and I'm going back to the immunology world of NF-kappa being this responsible party of dysfunctional regulation of inflammation, which then relays to neurodegenerative diseases, and not just the upper CNS, but the periphery. Chronic regional pain syndrome. You've got, like you said, the microglia in the upper CNS. They're responsible for so much of the neurocognitive response, central pain response, but you can also see it in the periphery in peripheral pain, but also, like you said, that gut brain axis neurodegeneration. It's just not firing right. And then when it's not firing right, everything is going wrong. What do we see? Postural orthostatic tachycardia syndrome.
POTS.
That's actually also related to neuro misfiring.
Interesting.
Small fiber neuropathies. This is another aspect of neurodegeneration. Like, just take your pick. And talking to the anesthesiologist and the sort of pain world, we know that all non-acute pain is related to activation of AMPA/NMDA receptors, but also as a result of chronic inflammatory response and sensitization and dysfunction in nerve activity. So it's not that the nerves are necessarily always being degraded, but you're getting a misfiring. Everything's just, you turned up the temperature and everything is just running rampant. And like I said, everyone's running around on edge. It's not just your immune system. Your immune system affects everything else, because everything goes to this sort of set point of panic, of pathogen attack. And so once you get there, what happens? You're running everything at a hot. And kind of looking at you, kind of, if I ran your GI tract at hot, what's going to happen? It's eventually going to start not processing properly. You're going to make different food choices. You're going to make low barrier choices of food energy system, because your entire metabolism has higher needs. What happens downstream from there? Then you see this neurodegenerative response and the gut brain axis, and your serotonin production goes off the charts. Now all of a sudden you're not functioning right. Your cardiovascular system isn't working. Your brain is collapsing. Like, it's just, so you're correct. Naltrexone comes in and just resets the entire system to a better point, normalization. And that turnaround time may take time, but once you get patients back to normal, their world is different. Like, it's dramatic. It really, really is. So yeah, it's not even an analogy. You're correct. That's how it's working. It's fixing the problem. It's underpinning disease.
Well, I think it's fascinating. Also, you had mentioned earlier about enhancing cancer treatment and cancer outcomes, and I'm just total happenstance ran across and it was just a brief reference to it, but there's apparently a Dr. Berkson in New Mexico who apparently has come up with a protocol dealing with stage 4 cancer patients, and they ended up utilizing pancreatic cancer patients who had, been given months to live, typically 5 to 6 months, and then able to demonstrate that dialing in low dose naltrexone actually permitted them to live quite well. For one was 2, one was 3.5, and one was a little over 4 years, and get a better quality of life. And some of them actually are still going, if I understood the paper correctly. But that was the reference point in there. And then I'd like to talk about that with you a little bit on low dose naltrexone and its applications in cancer. But just as an adjunct to that, I lost my own dad to cancer. And one of the things that but one of the things that he suffered from later was, and Ken totally remembers this, but he had a crazy trigeminal neuralgia, and it just wrecked his face. I mean, like, it was always on fire and pain it's called allodynia for those who are keeping up. But I mean, it's just an inexplicable pain from something that shouldn't cause pain. It's just, wind touches his face and it just felt like it was on fire. And there were a couple of things that we tried. And ironically, we did use low doses of some traditional opioids, and that would give him temporary relief. But that kind of inspired me to look up, does anybody use low dose naltrexone in treating trigeminal neuralgia and other neuralgias? And there's actually a lot of people who do it, and it works pretty well according to those who've been in practice with that. So from cancer to neuralgia, can you kind of describe how you've helped people with that? I mean, I'm sure it's a really small window. It only takes like a couple seconds.
Yeah, very small. Okay. Cancers, all cancers. Okay. So I'm not saying I'm going to cure cancer in this statement.
Sure.
But if we look at the underpinnings of all cancers, and there's information dating back to the 1800s, the late 1800s, is that there is a tumor microenvironment that is seeded with chronic inflammation in the body. Okay. So that's number one. Number two, it's a dysfunction of your immune system to identify and clear these cells that the cancer then takes hold and continues to grow. So it's a balancing act of the tumor microenvironment not allowing this recognition by the immune cells to actually identify and clear. And if you have immune dysfunction behind the tumor microenvironment, hey, everyone's on guard. We don't know what we're doing. And it's not able to target nor appropriately attack. This is where you can see that sort of start and slow tumor progression. You have a different environment in that tumor microenvironment. You have different cellular functions happening to allow expression of different cellular identification targets. And I'm speaking at a very high level, but when you're talking about cancer, the tipping point is this uncoupling of your OGF receptor access. And I mentioned this early with Dr. Ian Zagon and his team's work, that they've talked about this OGF receptor activity leading to normal growth, the inability to heal, which is a bigger deal in your geriatric populations, and this hyperproliferation of tissue. So anything from hypertrophic scars to keloid scars, but most importantly, metastatic cancer growth.
Sebastion, would you please, I've never even heard of OGF. What does that stand for?
Opioid growth factor receptor.
Cool.
So, and there's a whole group of people that, and Dr. Zagon and his team, and there's a whole group in the low-dose naltrexone world that this is the entire focus of their research. And then there's the entire group that's looking at the TLR receptor activities in tumor progression. And so the inappropriate ability to identify and then attack tumor cells. We know what happens down in the DNA and this conversion of the cell to a non-differentiated cell and then uncontrolled growth. But it's the opioid growth factor receptor where cancer, and Dr. Berkson's paper comes in, is using low-dose naltrexone allows the stabilization of that receptor access to normalize or prevent metastatic or unchecked growth. And so to your point, pancreatic cancer, he used an ALA, so alpha lipoic acid, as well as the low-dose naltrexone protocols, and it literally stopped the tumors from growing.
Oh, like lowering blood sugar as well? Is that kind of the...
That's part of the ALA piece, which was going back to the tumor microenvironment is very sugar dependent for anaerobic function, right? So this is why your white blood cells don't like that environment, because there's no food for them. So, but going back, the OGF receptor access, when uncoupled, allows for the rapid proliferation of tissue growth. This is a MET5 enkephalin endorphin. Let's go back to Dr. Bahari's work, the natural endogenous endorphin production. In cancer patients, we see it kind of doing this. So now we have a threefold effect. We have TLR activation and modulation. We have the opioid growth factor receptor stabilization, and we have endorphin production for these cancer patients. And so not only do you change their perspective on their cancer, you stabilize that growth. So all of a sudden you see this normalization of the tissue growth pattern, so it doesn't proliferate and take off. And you have your immune system is then better able to clear. And then this paper came along in about 2018, where they noticed that if you do CBD prior to low-dose naltrexone prior to chemotherapy, you will see a better uptake of chemotherapy into said cancer cells. Unknown mechanism, but there you go. Like, we don't know.
Sure.
So I think Dr. Berkson's work, he did some really great work on this. Dr. Zag, that was based upon Dr. Zagon's, but now there's a whole oncology world which is saying, like, look, we've got to use naltrexone earlier in cancer treatments along with everything else, because we want to stabilize that inflammatory process. We want to stop that OGF receptor proliferation access, and we're going to see a better uptake of recurrent therapies. So those are not my words. 2019, there was a couple of oncologists that got together. Now we're seeing more and more papers. So back to your colleague who said there's no science for this, I'll send you some documents through Allen Family, and you can be like, so there's no science? This is literally what the oncology world is doing. And I can talk about a number of health systems that we're currently working with in the compounding world that are using naltrexone in these purposes. So cancers, here's a pretty straightforward one. I had another pharmacist call me, and he said, what would you do for a patient with pancreatic cancer and why? And I said, well, you got about 6 weeks to 8 weeks if everything goes well before things start going really, really wrong. And I'm talking to 2 physicians, and you've probably seen this. From diagnosis, stage 3 to stage 4 pancreatic cancer, it can be anywhere from 8 weeks to about 12 weeks, maybe 16 weeks if you're really lucky. Unless you have a bunch of treatments, and that may not necessarily work. For a patient to survive 5 years post-care on just ALA and naltrexone was staggering. And I think that paper was from 2007 or 2009. They followed it up with multiple other patients. So of course we're like, here, just put it on board. What's going to happen? And what we see is that stabilization of tumor growth. Specifically, we're trying to get imaging from, I've got a colleague in Georgia. He actually had a family member, brother, who passed away from pancreatic cancer, as well as a father who passed away from pancreatic cancer. When he was diagnosed, his first question is, what do we do? And I'm like, LDN 3 to 4.5 milligrams, 5 days on, 2 days off, start tomorrow.
So you didn't do the typical slow ramp up. You were just like, we need you at 4.5.
Not in a pancreatic cancer patient.
Okay.
I don't even want to wait 2 weeks. You're starting at 3. If you can tolerate 3 for the next week, go to 4.5. But it's 5 days on, 2 days off.
Because the mechanism different with the OGF receptor versus the very specific TLR receptor.
Yeah. And I'm not worried about a few weird dreams, honestly, because we're going to come back to that dream discussion, I promise. But we're trying to stop a tumor from taking off.
Yeah.
Okay.
How is this? This has been written about. How are we not talking about this on the regular?
Well, there's no patent protection, and the only people who are marketing this are pharmacies and providers like yourself, who you learn about it and all of a sudden you're like, this is great. So you deploy it in your practice. And why do you start getting more patients? Because you're seeing these positive results, and the patients are all talking to each other, and they're all on Reddit. They're all on different boards, and they're like, oh my God, you got to go see Dr. So-and-so. And if you're not seeing Dr. Brown, then you're missing the boat. And then you're getting pharmacies who are also supporting this, but there's no patent protection. There's no big pharma behind it because they're not going to make any money. And it's so individualized, you can't just give everyone the same. So,
you bring up pharmacists. Would you also say that the pharmacy chains that have the most money, they're not into compounding, so they're probably not really interested in moving LDN nor purporting its success whatsoever. I mean, that's why we have people like Allen Family Pharmacy being able to do that kind of stuff, and the money and the lobby behind somebody like in big pharmacy like Walgreens or CVS, they're not going to be interested in anything like that.
Yeah, I want to get into that part in just a second, but talking about the literature, just so that if anybody's listening, I did do some literature searches and found clinical trials on multiple sclerosis, positive benefit, Crohn's disease, positive benefit, rheumatoid arthritis, lupus, SLE, as well as, of course, we've touched on it, fibromyalgia, chronic regional pain syndrome, but then also there's some studies on autism spectrum disorder. There's some animal studies, not so much on human, on Parkinson's. And then I was going to bring up cancer, but you freaking nailed cancer there. And psychiatric disorders, depression and anxiety, PTSD, psoriasis, psoriatic arthritis. And I've heard of an N of one person that got good benefit with rosacea. I mean, we'll keep it HIPAA compliant here, but he's in the room. So,
Well, if you ask him about his practice, I think he's got a few more patients that they're seeing the same thing. So, but
so it's definitely out there now. Okay, so if I'm listening to this, it's like, fine, I get it. I need to be on this. Where do I get it? Who do I trust? How does this process happen? All those things. And then we'll talk about who not to give it to and potentially side effects. But can we get into the whole aspect of what Eric just brought up? Your typical ginormous pharmacies don't get into the compounding aspect, and not all compounding pharmacies are created equal. Can we talk about where do I get quality LDN?
Well, you are now talking my language. So I'll try and keep this really brief. There's a different levels of practice within pharmacy, and patients may not understand that there's your local pharmacy, which is a chain pharmacy, which is very focused on lick, stick, and pour, which is low barrier to work. Hey,
sounds like a really bad adult film.
Yeah. Okay, we're gonna try and keep this clean here, guys. So CVS, Walmart, Walgreens. Oh my God, I just don't even know what to say. But these guys, they literally, it's like you kind of, drink some coffee. And away you go. You're pouring out just bottles and that's it. There's a very high focus on high volume, low patient sort of need. And that's not a criticism of that business model. It is extremely successful because CVS is one of the biggest chains in the world. When you talk about a compounding pharmacy, they've actually gone with a different perspective of pharmacy where they're saying, look, we're doing custom medication specifically for an individual patient with this high requirement, high regulatory environment, not only from the FDA, but from state boards and multi-jurisdictional state boards. So for example, a pharmacy may be regulated in multiple states because they may ship out of state, for example, not all. So when you have such tight regulatory environment for high specificity of patient need, they have to be invested in it. They'll have a distinct lab, they'll have distinct education components. Not to be rude, I finished pharmacy school and I was offered jobs at all these chain pharmacies and they're like, no, you can just jump into practice. I'm like, I've worked for the last 5 years in a compounding pharmacy as a student tech, and I still don't know what I'm doing. And they're saying, once you become a pharmacist, then we will train you appropriately for a compounding pharmacist role. That's where that first 11 years of my career came in before I even moved into this consultant role. Was, to me, that was training. Then I got to this role and I'm still learning, and it's truly a committed compounding pharmacy that is invested into doing things correctly. So when you talk about quality LDN, when you talk about quality care, the difference is if you can walk into a pharmacy, hey, can I speak to the pharmacist? I have questions about LDN. If they look at you and they go, I don't know a lot about it, it's immediately like, this is not going to be a place that I can get the appropriate care, let alone product, because they don't know what they're doing. They don't know how to do dose titrate. They won't have access to any of the tools that we've even discussed, and they wouldn't know where to point the patient. So it's a big fall down. Functional medicine providers, that's where I would suggest first and foremost, like the two of you have gone on to the functional medicine world. And so I'm not saying it's just a clean allopathic break and you have a special designation. You've done further education, and the two of you have said, we don't know enough. And that's the kind of provider I'm looking for, because they are always looking for something better. They're always looking to improve their practice, and they're willing to say, I need the education. That if you can't find a provider like that, they may not necessarily be the best interest of the patient. This is the way we've always done it. This is the only way to do it, and there's no evidence. Sound familiar? And then putting the two together, because an appropriate compounding pharmacy will have relationships with providers. And I'm just going to kind of give a list, not only physicians, but PAs and NPs who are educated and aware and are already thinking there's a value to this in adjunct care for this patient. And so they're already there. So if you find a good compounding pharmacy, they can point you to a good provider. And now you've got this beautiful relationship of patient, provider, and pharmacist who are going to have this ultimate outcome for the patient. So for me, the simple one is find a good compounding pharmacy first. Ask the questions. What do you know about low-dose naltrexone? Great. Do you have any provider recommendations? Or you make your way up to Plano and you talk to you two. So no pressure on your practice.
Yeah, we did have a talk with Joe before this, and I did pin them down on a cost, which I think is important because, when I have patients that are spending $15,000 a month on a biologic, at least at Allen Family Drug, they price their naltrexone. They're very upfront about it. And a 30-day supply is $45 and a 90-day supply is $110. And they don't really believe that it should be based on the dosing. They base it on the compounding. Am I correct on that? Or 4.5 milligrams, or because it's ideal for the patient. You guys are making the fixed cost for a patient, so somebody shouldn't be punished if they need more, and you just want optimal.
I told you this before the podcast. I've been compounding naltrexone for about 20 years, but I started reading about it for rosacea for myself, that it could control the inflammatory response. So I went to a dermatologist, got a prescription. He agreed to try it out, and it worked fabulously for me. So then I was invested personally, and I said, this could help so many different people in so many different disease states, or it's at least worth a trial at the very least. But they got to be on it for the 3 or 4 months at least to see really what the benefit is. And then I said, I don't want money to be an impediment. So if you make the price the same based on day supply, regardless of strength, if you're titrating up at 0.1 or you're at 10 milligrams because you're doing something for behavioral purposes. I didn't want them during the titration to feel like it was getting more and more expensive. So and frankly, I made it, you'll find that price, at least pharmacies in this area, to be really inexpensive. But again, it's my own passion for what naltrexone can do that I just want to help other people.
If it's okay, I'm going to jump in here. You mentioned that you've got these biologics, which are $15,000 a month. Even if you have good insurance, the copay can be still hundreds of dollars, if not touching $1,000. Even if they're getting help, it can still be prohibitively expensive. And I know Andy and Joe, they're working so hard for the community to make sure that this is much more accessible. And the funny thing is about compounding is that it's a lot of personalized professional effort to create these drugs from scratch. The cost of the drug is one small piece. It's the lab, it's the education, it's the training, it's the equipment, it's the effort. And so that's where you see this sort of cost that comes in. The drug is the drug, but they're making it for you specifically from scratch. It's a bespoke drug care, which is the difference between a good quality versus what our lipstick and poor colleagues are doing, who are buying it from a manufacturer, counting out by 5s or 10s, and then drinking their coffee and going home at the end of the day. They have a role, but they're not like a true compounding pharmacy. So there you
go. Should I, as a,
yeah, Joe.
Sure, Joe has a question here.
Not a question, but just a point to show how we differentiate a little bit more than even some of the compounding pharmacies out here. I want to make a point that I use in my marketing. Andy's got special credentials that I would like him to share that kind of set us apart as far as for the ability to have the best.
So some credentials here from Andy.
Yeah. So I've been compounding for 31 years. During that time, I've had numerous opportunities for additional education in compounding. At some point, they decided that I'd had enough, that I was bestowed the fellowship in compounding from a national organization called the Alliance for Pharmaceutical Compounding. And with that, we do a lot of training of students as well to kind of give back, but so, yeah. And as far as being credentialed, there are numerous types of credentials you can have in compounding, but being a fellow is one of them.
Okay. So Sebastion, I have a question for you. So I'm listening to this podcast and I don't live anywhere near Allen Family Drug, but now I really realize that I need naltrexone, and I go into a compounding pharmacy and whatever. I'm in Omaha, Nebraska, and I walk in and I said, do you know anything about LDN? They're like, oh yeah, I love LDN. I went to a conference. This is coming from somebody who also really enjoys learning about peptides and other things like that, and everything comes from the source. Is there a particular way to know that they may know about LDN, but are they getting a properly sourced low dose naltrexone? Is there anything that I should ask in regard to that?
So, and I obviously I work for a company, we sell these products. There's a very simple one, is you look for a PCCA relationship. We're the leader in compounding. We've been doing this for close to 50 years now. As a company, we provide the highest quality products in education. So the easy one is an ACP or APC, Alliance of Pharmacy Compounders designation, a PCAB accreditation, and then whether or not they work with PCCA. Those are some simple ones, and those are the acronyms that we use. So Alliance of Pharmacy Compounders, again, PCAB, Pharmacy Compounding Accreditation Board designation, or PCCA, Professional Compounding Centers of America. When you're working with those kind of acronyms, you kind of tend to skew to, I'm invested, I'm educated, and I'm working towards the best outcome in the compounding space. So a really simple one, you can find a compounder.com. You can plug in your zip code and then set an area around it. And that'll set you up with compounders that we already work with that are within our umbrella organization of excellence. So there you go.
Findacompounder.com. Cool.
At the conclusion of this, Sebastion, if you don't mind, and for all the listeners and physicians, et cetera, that are tuning in, send me the links to all of those. And in the show notes, it'll be super accessible for anybody. So if you don't have to,
Perfect.
if you're driving and you want to back up the podcast and listen, just know that in the show notes, all of these links that Sebastion's referencing will be available at the bottom. So,
all right. So final thing.
Okay.
Somebody walks into Allen Family Drug. They're only wearing a right shoe. They walk up to Andy and they're like, I heard this podcast. I want some LDN. And what are the questions Andy needs to make sure that they are not a candidate for LDN?
Are you taking opioids? And they're kind of like, it's always that's the big one. If you have a patient who's taking an opioid medication for pain management, for any reasons, we usually proceed with more caution. We can still use it. We just have to use much lower doses. So that 10 microgram to 1,000 micrograms or 1 milligram, we range them in there. We can actually still get some profound results with those lower doses. Number two, what have you tried? Where are we in your current therapy? And who are you working with as a provider? From there, then it becomes a discussion, and then we can identify them. But there's not a lot of people out there that are not candidates. We've had some very high dose narcotic patients start on much lower doses and still see an improvement in their overall care. Remember, Purdue Pharma, they were looking at this in 99. We just have to dose them right.
mm-hmm.
When we start talking about other patients that aren't candidates, it might be a sensitization or an allergy, but really and truly, it's kind of hard to say who's not in the pool of that 10%. Usually it's going to be, we've tried it. It might be another driver of disease, which unfortunately we have genetic dysregulation, which we can't control. It may be honestly, and this is a very unfair statement, some patients may not be ready to undertake all the overall changes that are kind of coming with naltrexone. And I'm going to probably say this as a GI specialist, you've seen it. Hey, I really need you to stop eating this, and I really need you to stop doing that, and I need you to be compliant with your medication. Yeah, no, I'm not into that. Okay. Like, no matter what you do, you're going to fail. They show up late for their appointments. They won't do their monitoring, and they won't take their medication, and they certainly won't change their lifestyle. There's only so much that naltrexone will do. And so we have to really set those expectations. So.
That's super. Hey, you said you were going to get to the dream aspect, so I don't want to leave everybody hanging.
Okay. There is literature, and you can find it. You can put naltrexone, TLR4, microglia. That's a really good Google Scholar search grouping of terms. You can put it back to about 2019. You're going to find actual documentation and data that says this is how it works. This is where it works. This is the impact on the microglia in white blood cells. So what do we do with the microglia? Well, they're the caretakers of your neurons in your brain, right? So this is where it gets fun. If I clean up the function of your brain and I take away the inflammation in your brain, what's going to happen? Your brain's going to be clear. You're going to be sharper. You're going to have better clarity of thought. We see this neurocognition. When you asked about autism, we see a decrease in neuroinflammation. We see a change in behavior, and we also see a change in pain perception. There's a lot of adverse behavior, so we can do up to 15 milligrams in pediatrics. But for those autistic patients that are brain inflamed, they really kind of come into line. By the way, we've also missed on ALS and epilepsy. They're actually doing trials. Stiff person syndrome. Celine Dion, I swear I want her to get on naltrexone. That's a different discussion. But to the brain aspect, when you clean up the brain function and I can caretake your brain and I can get rid of all of the junk in your brain and it's the waste material, what do you think is going to happen to your dreams? You're going to get like eating a really big cheese pizza and wings and some beer. You're going to have some pretty wackadoodle dreams because you're detoxifying. If I had naltrexone in and I start making everything work better in your immune system, that dream component becomes very vivid. It can be frightening. It can be like you wake up and you're like, whoa, what was that? Like hyper realistic dreams. And I think someone said Technicolor Dreamcoat sort of level dreams. just kind of off the hook, sort of a combination of Wizard of Oz and Donny Osmond singing at you in bright, bright colors. It's a little overwhelming. And the last thing I ever want to do to any patient is to disrupt sleep, because once you disrupt sleep, you can actually kick off a stronger inflammatory response. And now back to the discussion of lifestyle. Yeah, I'm doing shift work. I'm doing like all I do is work nights and I can only get 2 hours of sleep a night, maybe.
Ugh.
Yeah, it's only so much I can fix. So with those vivid dreams, that's a sign of, A, we're getting some traction, your microglia are kicking in. But if it's too much and I'm disturbing your sleep, I don't want to do that. Oh, let's put it in the morning. Now I'm not going to affect your dreams. And we see this change in sleep pattern disruption. And so for the longest time, it was at night, because we knew that your immune system kind of kicks up and ramps up at night. This is why when you're sick, you wake up and your hair hurts. But by midday, you're feeling better again. Your immune system is really doing its job. It's doing all of its work and it's doing its caretaking. That's why sleep is so important to rest. So if I mess with that, I'm really messing with the patient. But if I put it in the morning, I'm still getting the same action in your immune system, but now I'm not getting the nasty side effect of those vivid dreams. And so we've seen this change in the last 4 or 5 years, where it's naltrexone in the morning. If they want to switch to night after 3 months and that works for them and they tolerate, then it's appropriate. But it's not part of the must be at night. And there's no must rules in naltrexone anymore. It's really opened up, and goal-oriented physicians and like yourself, you're starting to really turn and go, the goal is to make the patient healthy. So we got to find the right dose for the patient. If you want a new goal, dial in the patient. Don't worry about the dose. Let the pharmacist worry about the dose. Dial in the patient.
Yeah.
Yeah, I have one more thing I wanted to touch on before we let you go, because we referenced it earlier, but many people have utilized low dose naltrexone for weight. Now, some people mistakenly say weight loss, but it's really, the way I understand, it's more about weight management. And the way it was explained to me as I dug a little deeper was that if you look at the hypothalamus, it's like this barometer. It tries to find your body's normal. And you lose weight, and although it may be healthy to have lost that weight or that percentage of body fat, it's almost like the hypothalamus is like, well, we've got to figure out how to bring the weight back up. We're missing it. Or even if you gain a lot of weight, you may end up losing it because the hypothalamus is helping you burn it off. The way I understood it, it's almost like the naltrexone allows the reset to the healthy, desirable level that you're after. So maybe if you ended up losing a lot of weight and then you began LDN, you may actually be able to better accommodate the more fit person. Is that kind of right?
Yeah. So we've been talking about the TLRs and the OGF receptor access. The 7 opioid receptors are not only a pain receptor or a pain management receptor, so to speak, in the anesthesia world, but they're also responsible for a lot of endocrine and homeostatic function, normal function. So GI function, hypopituitary function, endocrine function, temperature, stress regulation. So the opioid system isn't there just for pain management. And so and this is where it worked in the alcohol use disorder. It doesn't make you throw up if you drink while you're taking naltrexone. You just lose the desire to drink. You don't get the reward system. And that's part of the opioid behavior response. But with respect to weight loss, you touched upon it. It's a regulatory sort of homeostasis. It renormalizes the body to, hey, where are we? But it's also changing behaviors or pattern around food. It takes away the cravings, because again, we're moving away from addictive behaviors. And this is why it doesn't work in everyone, because genetic SNPs in your opioid receptor, addictive behavior, naltrexone, bing, you turn off the addiction. It's that fast. In the lower doses though, you ready for this? Harvard did a paper on depression, 1 milligram BID. We saw an improvement there, but in these lower doses in BID dosing of naltrexone, we get the 2-for response. And this is what Andy had said, 4 to 6 to 10 milligrams divided into BID doses. You get the anti-inflammatory response, which is also crucial to that weight management in chronic inflammation due to visceral obesity. But you're also getting a behavior change in food addiction and food reliance. And you're also getting that opioid dopaminergic decrease reward when eating, so you don't get the emotional response or the reward response.
Oh.
And finally, the hypopituitary gland, hypothalamus pituitary gland, endocrine balancing and normalization. So your weight comes off more carefully, and you're changing your relationship to food, and you're resetting at a lower weight. If you're not doing naltrexone in conjunction with other weight loss treatments, you're missing this golden opportunity to stop people having that rebound response of like, okay, I've lost the weight. Now what? Going back.
I'm seeing this epidemic of what we're going to have, this rebound obesity with all these people on the GLP-1 agonists, because I've had both patients and colleagues who lost a tremendous amount of weight, and either through cost or through losing too much muscle mass or you name it, they had to come off. And there was a tremendous rebound, tremendous, whatever was tamping down. And we know that they're going for addiction. The FDA, they're filing with the FDA for addiction uses, but whether it's a dopaminergic or a GABA or a serotonergic, who knows? Because they're still working that out. But what ends up happening is when they stop that, now we've got a reset very fast hypothalamic response. We've taken away the reward system, meaning that the GLP was doing something with getting people to not have those food urges. And my friends and patients who have come off of it after losing a lot of weight just start to rebound like crazy, and they're essentially forced to go back on it. So it only makes sense that if you're going to be on a GLP-1 agonist and you're going to come off, you need to stack it with LDN to prevent the exact thing that this thing was stopping. Interesting.
Isn't it fascinating that whenever you were talking about GLP-1s, that you brought up what is it called? And the anhedonia, the anhedonic.
Oh yeah.
And so, but we talked about that earlier. You said earlier that that some people have used now LDN to curb bad behavior like gambling, et cetera. It's almost like that's the safer mechanism.
Yeah. To
have anhedonia is something like LDN versus going straight to GLP-1, and then you'll probably get a better balance and not, it sounds to me like what you're describing is binge eating is what people would do. And what you're doing is you're curbing someone who says, well, I'm just going to have one. And then it turns into 6 bags of whatever kind of favorite chip that they've got. And then, I mean, then you feel guilty and all this other kind of stuff. But if you can curb that, then
yeah,
it would be far different. And it sounds to me like it would have, or well, almost no side effects whatsoever. And it's interesting also, sorry, one last thing. Well, all this stuff races through my head because I just got really excited.
I told you we could talk all day.
Yeah. I mean, I did get really excited, but what Ken said, he had a colleague that brought to his attention about utilizing LDN. And the first thing I told you, I was like, oh, is this because somebody's having an issue with opioid constipation? You know, you said that there are different uses in opioid receptors throughout the body. Yeah, you can just shut the door. Yeah, it's fine. The use of opioid receptors in the gut, whenever they get overstimulated, they actually cause constipation. Yep. And so the use of naltrexone in this particular instance, you could almost increase the motility in someone who's had an issue in and around GI issues. So I was just kind of assuming that was the application. But just as you've pointed out, there are so many different functions for opioid receptors throughout the body. Analogies. You said, I like analogies. When one person sees a sheet of unused plywood, if there's a hurricane coming, it's because you want to protect the window. But if you're trying to build a little desk at home, well, you know that you're going to cut it up and then you're going to do something. If you are sheathing a house that you're building, that's you're going to lay the brick next to that. I mean, it's one sheet of plywood is like naltrexone. We were all told that it was used for opioid addiction, but the truth is it can be cut, molded, and utilized in a bunch of different ways. If you're throwing a concert and it's raining outside, you're going to throw the plywood on the ground so people don't have to walk through mud. I mean, like there's just all different kinds of applications and ways to use something that's a tool. And naltrexone seems to vary.
I'm almost there. Can you give me 2 more analogies of what you do with this plywood?
So I'm not going to do it.
There you go. You can turn it into a CrossFit step-up box, so you can actually improve health and fitness.
You can build a a low cost wall for your.
Eric built this behind us, by the way. That's why. And he
That's
actually
really
designed the
nice.
sign, and
That's impressive.
he did that.
I did it for you.
He showed up. He showed up with a big giant piece of plywood, and I'm like, we don't have hurricanes. What are you doing? He goes, you'll see.
Yeah, you'll get it.
And this ended up being that big old plywood. So
That's awesome.
Sebastion, wow, we could talk forever, but this is a good starting point for me. I am a believer now, and I'm going to start implementing this on the regular for a lot of people. Where can people find you? Where can they get some more information?
So I'm going to defer to my amazing colleagues who are in compounding pharmacies all over North America. That's where you find, because it's great if you can talk to me, but I can't give you the help that you need. Whereas your local compounding pharmacy, so Joe, Andy, perfect at Allen Family Drugs, is a perfect place to start, because they have relationships with providers. They have up-to-date information. And if they have a question, they know how to get a hold of me directly. And so we can work through individual problems, but they already have an amazing breadth of experience. They don't have to talk to me about everyone. The LDN Research Trust is an open source website. If you're looking for more information, you're looking for dosing information, you're looking for even providers or pharmacy sites. They have fellowships that they've done with LDN specific providers and pharmacists. And more importantly, there's a ton of open source information. They also have a podcast, they have videos, they have papers that are available, and they have 3 books so far. They have LDN volume 1, 2, and 3, the LDN book. And so there's a ton of information there. So to talk to me though, you got to talk to Joe or Andy or one of our compounding pharmacists. And the reason why is because I'm only one person. And this is why this message is so important, because I've talked to the 2 of you. Now you're going to go out and you're going to take care of all of your patients, but you're also going to become a maven to other providers. And so I don't want to be the one guy. I want to be a positive influence to the people who are the big influencers like yourselves. Like you're doing amazing stuff by having a podcast and making this accessible to so many patients, because this is the dynamic. If we get the message amplified, then we will get better outcomes for more patients. So there you go.
Great.
Yeah. Wow. Thank you so much for joining us today, Ken. Anything else before we?
No,
Let him
definitely
go?
appreciate. I learned about it from Joe early on a few years ago. He introduced me and I played with it, but didn't really do the deep scientific dive that I needed today. I'm the kind of person that once I wrap my brain around how, then I feel like I can implement. And you've done an excellent job of explaining the various aspects of it. And yeah, thank you so much for taking the time, Sebastion. And, hopefully we can get the word out a little bit. I will give you some feedback in 6 to 9 months about how well my patients are doing once I have it completely dialed in.
That's perfect. Thank you.
Well, everybody
Thank you
listening
for
to
having
GCP, thank y'all so much. Sebastion, thanks so much for being a part of the show. We will catch y'all next time. Be sure and check show notes for all of the references that he shared with us today, and we will tune in for the next show.